Good afternoon. I'm Andy Rux from the South Central Center for Public Health Preparedness and the University of Alabama at Birmingham School of Public Health. Welcome to this broadcast. Today we're here to talk about a multi-state, multi-organizational solution to limited regional medical surge capacity in the Southeastern United States. Through the experiences such as Hurricanes Ivan and Katrina, pediatric providers learned that traditional approaches by themselves would not be effective in addressing the complex, multi-institutional and multi-jurisdictional nature of a regional pediatric surge. In today's broadcast, we will discuss the efforts of more than 40 organizations who have worked to plan and organize the Southeastern Regional Pediatric Surge Network. I'll begin by introducing the panel of experts who are with us today. First, Joyce Pearson, Office of Hospital Preparedness, Mississippi Hospital Association. Ken Beeman, Office of Emergency Planning and Response, Mississippi State Department of Health. Steve Baldwin, Children's Health System of Alabama. Leanne Roofing, Monroe Carell Jr. Children's Hospital at Vanderbilt University, and Maury West, Social Work Director at the Alabama Department of Public Health. I wish to remind you that you will have the opportunity to speak with me and the panelists directly or email questions and comments. Throughout the program, you will see a toll-free number and an email address on the screen. You may call or email any questions or comments you may have, and we will answer them as we receive them. Also, the handouts, sign-in sheets, and evaluation for the program are available online. You will need to register in order to have access to them, and we are offering continuing education credit for nurses and social workers. Today's broadcast is produced by the South Central Center for Public Health Preparedness in collaboration with the Alabama Department of Public Health. Funding for the South Central Center for Public Health Preparedness comes from the U.S. Centers for Disease Control and Prevention. Funding for the project being discussed today is provided by the Alabama Department of Public Health through a grant from the U.S. Department of Homeland Security and by the Mississippi State Department of Health through a grant from the U.S. Centers for Disease Control and Prevention. If you would like more information about the South Central Center for Public Health Preparedness, you may visit the center's website. We'll get started. Maury, as representing one of the sponsors of the project we're discussing, would you mind addressing for the audience the importance of this project to the Alabama Department of Public Health?
Sure, Andy, I'll be happy to. I came to public health in 2004 as the emergency preparedness social worker, working in the Office of Professional Support Services very closely with the Center for Emergency Preparedness. And I feel that our agency has always had a strong commitment toward identifying and planning for persons with special needs during a disaster. And of course, in that group, children are a major component of that. I think every time when I pick up the paper, see something on the news of a bus crash, something like that, our system could be easily overwhelmed. In the state, we have one true children's hospital. We have two others with true pediatric capability. So just last night in talking to Leanne, we were talking about Children's Hospital in Vanderbilt, and they're at 90% capacity. And I'm sure Children's Birmingham stays full most of the time too. So we would be strapped. And in early 2005, the concept of pediatric surge was presented by Steve and Dr. Farguson to our HRSA coordinator in an effort to say, what can we do about this? A work group was formed and protocols were developed for pediatric disaster treatment. They were distributed to hospitals throughout the state by our emergency preparedness coordinators. And a number of conference calls were made, and one group meeting was held, which included Florida, Louisiana, Georgia, Mississippi, and Tennessee. And it was kind of ironic because as that meeting was taking place, Katrina was forming in the Gulf. So I think we've seen the importance of this. Because of that, we continued with our efforts by supplying our EMS with a number of pediatric-specific items, Broslow kits, papoose boards, things that were much needed by our ambulance services across the state. In 2006, we looked at the psychological and psychosocial aspects of children in disasters through a Safe and Sound conference, which we partnered with y'all on, along with several other agencies. So it's been very important to this department, and a major thing that I have enjoyed working on because of the enthusiasm of the people here, as well as those that come to the meeting that really love children.
Thank you very much. I might mention that I forget the title of the conference, but there was a parallel or a replication of Safe and Sound held in Mississippi the following year.
Right.
Ken, would you mind addressing the issues surrounding the need for pediatric surge from the Mississippi perspective?
Well, I'd certainly be glad to, Andy, if, of course, you'll indulge me for just a little private extension of my pleasure and my gratitude to be among this group today. It's been, I would echo in a number of ways Maury's comments. Not the least of the advantages to me personally has been to be able to work with such a cordial group with a fairly solitary, if not monolithic, goal toward looking out not only for the next generation, as it were, but for a group that enters the world quite vulnerable. And I'd like to very much say thank you to our hosts here at the Alabama Department of Public Health today, this marvelous facility. And I appreciate the long-term commitment that the South Central Center for Public Health Preparedness has demonstrated, and the fact that for you guys, this is not just a 25% of your income generation. You feel it. It's a palpable commitment. It's a passion that we share. I would be terribly remiss not to acknowledge my grateful feeling toward my colleagues back in Jackson at the State Department of Health. We enjoy a tremendous amount of support from the top down with Dr. Mary Currier, our new state health officer, Mr. Jim Craig in the Department of Health Protection, the Division of Health Protection, had a real keen vision for this, supported by Mr. Seawright in the Office of Emergency Planning and Response, and my colleague, Mr. Jonathan Cheney, who is in hospital preparedness. Mississippi, where I wanted to go with here at this point is to kind of give you a context or a background as to why this proposal gained significant traction from the get-go because of, I guess, who we are, where we are, and a number of features that speak to our basic health status and to the resources that we can tap into. You know, if H1N1, which has been a significant, had a significant impact on our nation, with just a few tweaks in the RNA of that virus, this could have been substantially more impactful than it has, and it would have represented kind of the colossal bus accident or tornado, that sort of thing, in the fact that it would have strapped all of us at nearly the same time. You know, in Mississippi, when physicians see a child who is very sick, unless those circumstances happen in Metro Jackson, close to Memphis, or on the coast, the disposition for a very sick child is a tough one. We have fairly limited resources. Like Alabama, we have really only one true full-service pediatric dedicated facility with a number of great regional hospitals who can fill in and stand in the gap, but in terms of providing that comprehensive approach, we are by nature a state dependent and interdependent. So the idea of us looking toward the development of a system or a network which had built-in processes and procedures that gave us more support and more foundation. You know, in all of medicine, and certainly in pediatrics, we depend on professionals at every level to do a Herculean task. But when it gets to the point that one's resources are always at the edge of exhaustion or always at the edge of some sort of potential scarce description, tensions develop. It becomes very tight. So the notion that we can have a framework that therefore let us no longer have to depend on the supervigilance of highly motivated individuals for for success to happen has great appeal personally to me, and I think overall to the department. You know, the nature of reimbursement for point-of-encounter health care in America has clearly come to the fore. We've all had a chance to reflect upon the ongoing health care reform debate. But at some level, when one aggregates these number of near-miss possibilities at points of encounter, so to say, it does in fact become a public health problem. And I'm thankful that, as I say, my associates back at the central office in Jackson see not only the potential for disaster in the right set of circumstances, but a great opportunity for relief. And I guess that allows us to go on to this next slide. So I would, as I say, try to paint you a picture again in a more tangible way as to why the notion of the Southeastern Pediatric Surge Response Network has real appeal. If you'll notice on this slide here, I've attempted to demonstrate a couple of demographic issues that are not necessarily carte blanche descriptions, but they act to some extent as a proxy for where we find ourselves. Is it a crossroads or is it behind an 8-ball? You'll notice we have a comparison to the United States overall averages here, as well as our sister states, most of which are going to ultimately be participants in this network. Mississippi is a young state. I've selected the 18-year-old cutoff here because the census data readily yields this kind of summation. But as you can see, all of us roughly have a quarter of our population in what could roughly be considered the pediatric age population. But here again, Mississippi has a little extra percentage point here. And unfortunately, we are always at the top, if not the very top, in the percentage of our population at or below the federal poverty level. And again, not that that in and of itself is a causative factor, but it's clearly associated overall with access to care and overall health status. And so we start out again, potentially either being at a crossroads or behind the 8-ball. On the next slide,
Ken, could I interject that if you're unable to see these slides on the presentation, they're in the handout. So I don't know if they're on the screen or not, but they are definitely in the handout. So sorry to interrupt, Ken.
No, thank you very much. A timely tip, to be sure. In addition to what the makeup of the population and the huge importance it has to our state, I wanted us to look at where we stand in terms of having the physician corps to support that population. Again, these are statistics from this slide came from the Kaiser Family Health Foundation statefacts.org if you wish to verify or to check for your own situation in other states not represented here. You'll notice that, again, for the United States overall national average, primary care physicians per 1,000 of population, this is not 1,000 children, but just 1,000 of the population, you roughly got 1.2 physicians seeing that 1,000 group of people. In Mississippi, among this group here, the numbers, the differences are not large until you begin to extrapolate them over the fact that you're seeing a large quotient of the population. You might look at the fact that while in Mississippi, one physician is going to end up potentially needing to take care of maybe 1,100 or 1,200 people in the same time period that a physician in Alabama would see 1,000 folks. So day in, day out, year in, year out, that begins to be a cumulative effect. Now, within the primary care physician category of healthcare provider, I've looked at two carve-outs here, not at all willing to neglect the important contribution of family care physicians. This ends up kind of showing the relative split in each of the states, again, that we anticipate participating in this Southeastern Disaster Response Network. And remember, again, while these percentages look fairly similar from state to state, that is then a multiplier onto the fact that we in Mississippi start out with that 0.9 beginning point as to the primary care physician. So I would say that the take-home notion here is that in Mississippi, primary care physician force is not where we would like to have it. And then if one further analyzes the makeup of that corps, pediatric specialty is relatively underrepresented. Now the next slide, which may not in fact be broadcast, but you can pick up again from the packet of information. This, I guess to begin with, is a way of reminding me to tell you that in the public health system in Mississippi is a federated organization. That is, we have central organization and then various levels of both service and administration. We are a districted state in that sense, and it has worked well over the last several decades. The point here, without getting lost in all the detail, is that there are some geographical differences that are not wholly unpredictable within our state in terms of the distribution of pediatric specialty care. For instance, if you'll look in the northwest portion of the state, District 1, pediatrics is relatively, not relatively, but is more prominently underrepresented in this one area. When one does the calculations, again based on information drawn from the Mississippi chapter of the American Academy of Pediatrics and the Mississippi State Medical Association, where the membership have designated a special interest in pediatrics, we find that particularly in this one area, pediatric specialty would extrapolate, were it the case that only pediatricians were seeing the children in that area, where a pediatrician is responsible for 5,000 children. Now, if one looks at the mapping that the American Academy of Pediatrics shows as a distribution for the whole nation, they don't have a slot that reflects at a 5,000 categories. Basically, they stop at 4,000 and above. So, but then one can look at other areas, District 5, District 8, in which the quotient comes down to one pediatrician for every 2,000 children, which is a much more manageable. And then keep in mind that particularly in Mississippi, the family practice contingent of our primary care do a Leviathan job in terms of seeing a broad range of our citizenry. The next slide is yet another way to try to get a feel for Mississippi being at a crossroads or potentially behind the eight ball. Again, the same comparisons we've had to the United States overall national averages and then our sister states. One will notice that in terms of what we would commonly think as the private insurance background, we are the least in terms of the magnitude of the penetration of that form of healthcare insurance of this august group. And then we have a disproportionate enhancement of the portion of our state who are covered by Medicaid or S-CHIP, which is going to tend to be a reimbursement system that is at the low edge of its ability to support the service and resources that are frequently called upon. And then finally, we have a 13.5% in comparison to the national average of a little over 10%. Of those children who remain uninsured. Now you'll notice that Florida has a higher index in that category, as does Texas, and I could speculate, but I think that likely it relates to probably a larger portion of undocumented immigrant residency in those states. The next slide is a bit more of a one can say maybe even non-germane to our discussion, except again I want to use what are fairly commonly cited public health type proxies or surrogates to reflect the general health of the general situation of health among the citizenry of a state. Mississippi unfortunately enjoys the #1 status, another worst first if you will, with regard to our teen birth rate. We end up having a fairly substantial quotient of the overall percentage of preterm births, again, not only compared to our sister states, but the national average. And unfortunately, though we are making progress, we wind up with an unfortunate high mark, as it were, in infant mortality. We are perennially at #1 or #2. So those are challenges. We began at the get-go in Mississippi that would cause us to look for insightful, creative, innovative ways to leverage not only our resources but our connections so that we can do a better job in terms of, at the end of the day, believing that you've done what you could do to have our ability not only on a day-to-day basis to take care of one child who has a need, but the potential for a very large number of children in one particular disaster or cataclysmic event. My final slide is another one of our iconic Mississippi State Department of Health district maps. In this instance is to give you a sense of the designated pediatric bed availability in Mississippi. I'm not sure, I'll have to plead ignorance on what the American Academy of Pediatrics or NACRI would say would be the ideal quotient as far as that goes, but I think it's safe to say that with our cumulative 377 beds in Mississippi, which works out to about a half bed per 1,000 children on any given day, if all were available, that one could imagine that it would not take a very significant event for us to have that resource overwhelmed fairly quickly. So we see in Mississippi not only the fact that this issue tugs at the heartstrings of parents, physicians, those of us in public health, but it's a matter of good stewardship of our own resources, limited as they may be, but to try to make sure that we all start out at the same point and that we have an ability to allocate scarce resources in the very best fashion. So I thank you. I hope that kind of tells you why we embrace this initiative with both arms wide open.
And you bring up a very good point, and I would say that it contributes to one of the elements of the vision for the network, which is for it to be a highly collaborative among the various agencies, because you demonstrate that there are inadequate resources. The only way to even come close to acquiring enough is to collaborate with others who may have them. Which leads us, I think, into perhaps asking you, Steve, to think of this and talk with us about the issues from a clinical perspective.
Thank you. I also want to express my thoughts that it's a great privilege to be able to address everybody today. And I'd like to dovetail briefly with what the two previous speakers noted. I was involved a few years back in trying to help the Alabama State Department of Public Health better understand pediatric issues, and I want to give them a lot of kudos in that they've studied the issues, and I think that they've made a lot of progress over the last few years. And again, as Andy and others have alluded to, we've certainly had our fair share of natural disasters that have advanced our learning curve greatly as well. And I also want to thank our colleagues from Mississippi for coming and participating. And I think we've had some discussions with colleagues in Mississippi and elsewhere, and it provides some reality testing and further understanding of the issues. I think what I wanted to try and do today was to try to provide a bit of a perspective from a clinician's point of view, and also from a medical director's point of view, from prior experience and also some other experiences along the way. And what I've tried to do today is to talk in three domains. One is maybe to go just a little further on understanding the relative risk of why this is such an issue. And second, to present a little bit of the way that I think about trying to plan and respond to these kind of issues. And third, talk a little bit about the different reference frames that people work from and understand why there's some inherent struggles in that, because different reference frames can give different solutions to the same question. And I'm hoping that this will be a springboard to some good discussion in all of this. So I'll try and be erudite here, and then hopefully if there's interest we can discuss it in a little bit more detail later. As we've already mentioned, there's a pretty significant capacity limitation with respect to pediatric clinical services. A lot of what we're going to say, I think, applies to other regions of the country. There may be some differences for areas of the country that are in megalopolis zones, but most of the country, I think, is probably analogous to us. And again, children are about 25% of the population. Things that create a across-the-board impact, about 25% of the victims are going to be children. But even worse, if you have some insult that predominantly affects children, a daycare or a school, for example, nearly 100% of the victims are going to be children. And there are certainly hybrids of this where certain types of insults preferentially affect children, although they affect adults as well. And so there is significant risk because children represent a significant portion of the population. The other part of this is what's been mentioned to some degree before, is that the resources to deal with this are pretty constrained in many areas of the country as well. There's probably about 5,000 hospitals in this country, but only about 10% of them really provide high-end pediatric care. So that's a pretty constrained group to start with. And then the distance between the next pediatric capable facility is often hundreds of miles. And that's likely true in the south central part of the country for sure. One of the problems that we have in pediatrics also is that hospitals generally operate at near full capacity. In my hospital, actually, most every day is a mini disaster because we not infrequently board patients in the emergency department. We have an over demand for the limited number of specialists that we have. We have tremendous trouble in this state with getting people to have sufficient call coverage in various specialties because there's too few specialists and other issues involved. And the issue here becomes that it doesn't take much of an unexpected influx of patients to really tip that beyond the breaking point. I mean, we're usually near the breaking point a fair amount of the time. And so one of the important points, I think, is what may be a disaster to the pediatric community may not be what a public health department or a community would normally recognize as a disaster. So in our case, 20 patients that are seriously injured is a real disaster because we don't have enough ICU beds to take care of them. And they're going to have to be offloaded somehow or other. In the adult world, there's 6 or 8 hospitals that it can be diffused over in our metropolitan area. So it's probably not going to be quite a disaster in the same sense that it is for the pediatric community. There's certainly reimbursement issues that affect things, and I think we talked a little bit about that as well, and that mostly Medicaid and S-CHIP and to some degree private payers are involved in this. And so that's a little different than the adult world where Medicare and private payers handle things a little bit differently. We certainly have an ever-growing population of special care needs among children, and these are both acute and chronic. The number of organ transplants and other medical advances that have happened over the last several years has certainly created a much, much larger population of children with high acuity needs at baseline than 10 years ago or so. The other issue to keep in mind in all this is that if there is a disaster, we have to continue to take care of the baseline population. And in fact, during many disasters, the baseline chronic and acute care needs of the population that you serve is actually a greater issue than the disaster population. And we often tend to lose sight of that because we get focused on the disaster victims, but that's a real problem too. So when these kind of issues come up, I think the way that I personally tend to look at these things is a supply versus demand analysis. And that makes a lot of sense because we generally define a disaster as being a state where the supply of resources is inadequate to meet the needs for the resources. And so if you look at it this way, I think you're looking at it from first principles, which tends to be an effective way of looking at things, and it also ends up being pretty rigorous. And there's a number of things that can impact the supply and can impact the demand. But during a disaster, basically, you either have to increase supply, or you have to decrease demand, or you have to do both. And understanding the cofactors that determine those two issues, if you go through them one by one and try to analyze how you can optimize them, that's usually the most effective issue. And so internally, you're going to want to look at processes and human resources and supplies and equipment and so forth. And also on the demand side, you can look at offloading patients, redirecting patients, and so forth. But at the 50,000-foot level, basically you have a couple choices. You can either bring in more supplies, or you can shift people to where the supplies are in order to try and optimize the supply side of things. On the demand side, you can either temporize and try and stall for time until you can get supplies. You can offload patients, or you can triage and ration resources, and that's basically what you're left with. And when you're stuck at a single institution level, you pretty much get handcuffed pretty quickly in those kind of circumstances. However, if you can diffuse the problem over a bigger area and a bigger supply of resources, then it certainly gives you much more opportunity and flexibility to come up with a creative solution that's going to be effective and efficient. And so I think that's kind of how I apply that kind of logic to all of this. I think that there's probably a couple other pediatric specific issues that apply to this as well. One is that children have a much broader spectrum of size and physiology issues. And so when we talk about supplies, we have to be able to deal from the small neonate all the way up to the adult-sized adolescent. And so that creates a bit more stress on the issue. The second issue is that children have some unique developmental physiology issues that have to be addressed as well. And that makes it somewhat more difficult as well. And then finally, children have the family and caregiver issue that's bundled with them as well. And keeping families together and understanding that children are not self-sufficient and require a caregiver to support them ends up becoming an additional issue in all this. I wanted to take just a couple minutes to talk a little bit about the different perspectives of different reference frames in all of this. And I think perhaps this will help us understand why we struggle with this to a bit, and maybe be a springboard to talk about some of the issues in implementing this type of network. Generally, there's 3 or 4 reference frames that pretty much universally come up in this. One is the administrative reference frame, and that's focused on managing resources. Then there's the clinical reference frame, where I'm focused on an individual patient and trying to best optimize the resources that they require. And there's the public health perspective, and they're focused on it from a population perspective. And each of those reference frames gives you a little bit different answer. So let me take the recent H1N1 outbreak as kind of an example of this. The administrative reference frame is focused on obtaining enough N95 masks and enough Tamiflu and enough rapid flu tests. That's a little bit different than the clinician who's struggling with the patient at the bedside and trying to decide whether they have influenza or not and whether they'll benefit from treatment. And then the health department is looking at trying to understand the issues of the epidemic and trying to decide at a population level how to apply the resources. So let me give you a little bit of an example of how this ends up being a little conflicted sometimes. So the public health department notes that for the population, it's best if we can test them and figure out who has H1N1. The problem I have at the bedside is that if I do a rapid flu test and it's negative, there's still a very great possibility that they have influenza. If I try to do an H1N1 specific test, it might be a week or two before I get the result back. So I've got to decide what to do. And so my answer isn't quite exactly the same as the health department's. And this happens in other ways in disasters as well, in that we have legal and regulatory and financial and other issues that come into this. Depending on your reference frame, they can impact you in a little bit different way. So perhaps that may be a springboard for discussing some of the implementation opportunities and challenges in all of this. So I think in summary, what I would emphasize is that executing the basics and understanding the basics is the best way to succeed in all of this. And I think if people can understand the issues related to children and the pediatric population, then perhaps we can learn from some of our previous experiences and make some forward progress in all of this.
Thank you very much, Dave. Leanne, you've been very active in helping plan the network from as the project got going. You've been attending the meetings and making exceptional contributions to our planning efforts. You come from one of the adjoining states that's not in the sponsoring group. What interest does Monroe Carell Jr. Children's Hospital at Vanderbilt have in this effort?
Yes, well, thank you, Andy. And we received an invitation to help participate in this network approximately 12 months ago, and it's been a wonderful opportunity for us to have interstate communications and to really look at the pediatric needs in our region. And daily we're faced with the capacity issues at our organization. And I know through our communications with the other children's hospitals in the state of Tennessee that we're not unique in that matter. Tennessee has a framework that they've established with 4 designated comprehensive regional pediatric centers, or CRPCs as we call them. And it's a self-designation that you can have in the state of Tennessee, but with that comes the responsibility outlined by the state. And we at Vanderbilt are one of those, and we have 3 others across the state. And so we are more fortunate than our counterparts in Mississippi and even Alabama as far as our pediatric resources in the state. However, our capacity is strained daily. And so we were looking at opportunities to help address those needs, and understanding that with a disaster type situation that we would be placed in a very difficult situation to provide high quality and appropriate care for the pediatric population. So this network, we were thrilled about the opportunity to collaborate, and I think that's one of the key words of this is being a collaboration across state lines and going beyond just pediatric specialty centers who we typically collaborate with, but looking at our local providers, our community hospitals, our EMS systems, and all the different players that are needed in a pediatric response. So it's been a great opportunity. We see this as something that not only can we help our counterparts in the other states and in our community, but also in the event that we have an unfortunate situation occur, that we will be relying on them as well. So the network, in our eyes, provides a great opportunity to open lines of communication, to plan for events that may not be designated by the state or federal level as a disaster, but that we know that strain our resources that we have available to make sure that we provide the highest quality care, and looking at children not as small adults, but recognizing that they have unique needs that a network such as this can help support.
Thank you. George, you represent you're from the Hospital Association in Mississippi, and therefore you represent the array of hospitals. Talk about how that fits into this process of providing surge capacity.
Thank you, Andy. And I, too, would like to thank the Alabama Department of Public Health for the invitation to be here. And I apologize for my throat. But with the Mississippi Hospital Association, we work very closely with the Mississippi State Department of Health Office of Emergency Planning and Response, and with Dr. Beeman and his peers. And we have been very fortunate in Mississippi that we do have that centralized system in the state. It has made for great progress in the preparedness and the hospital preparedness role. We do the limited capacity for pediatric response has been an issue. So the HRSA, Health Resources and Services Administration, and the ASPR, Assistant Secretary for Preparedness and Response funding has been very valuable to the hospitals in Mississippi to help them to be able to enhance their capacity to respond to disasters, whether adult or pediatric. And so some of the work that the Hospital Association does in preparedness is to, a huge piece of this is in the role of mitigation and preparedness. So that is to access those funds that would help the hospitals in obtaining communication, better communication equipment, and multi-mediums of communication, in obtaining the equipment and supplies that would be needed to respond to pediatrics. Making sure that in all of the preparedness funding that we do include pediatric medications in our pharmaceutical caches that are staged across the state, and making sure that we have pediatric-sized emergency supplies in our special medical needs shelters, as well as in our state medical assistance, the mobile field hospital programs that we have. And very importantly, making sure that in all of the training that we provide training specific to the pediatric population. As Ken has pointed out, the fact that we have a very limited number of pediatric specialty hospitals in the state. Literally, there is one official pediatric hospital in Mississippi. So that in itself lends to the fact that healthcare workers in the 120 hospitals spread across our state, many of those rural, approximately 50% of those with 50 beds or less, that the staff in those hospitals will need continuous training in the field of how to respond to and treat the pediatric victims and patients that come into their facilities, whether on those daily basis, which gives them the opportunities to enhance those skill sets. And also the piece that comes with the emergencies and dealing with the pediatric population there is that as much as possible in those emergencies, and as Steve pointed out, that those pediatric patients will often come with a caregiver, a parent, a grandparent, those types of situations. So being able to manage those patient populations and to care for their caregivers at the same time. the other piece that we have, as Leanne pointed out, in Mississippi we have different levels of hospitals. We have some hospitals who are designated as centers of excellence for emergency preparedness. Those hospitals have stepped up. They have additional caches of medical supplies. They have additional personal protective equipment, and they have mobile decontamination equipment to handle hazardous material events. And those hospitals that will be able to, that have the decontamination teams, will be able to decontaminate the pediatric population. It's very important that they have trained and are skilled in that role as well. We have a second level of supportive center hospitals. Those hospitals as well are ramped up. They have the additional training. They've agreed to step up. These hospitals are spread across the state so that a response, they have resources staged in these hospitals so that the response could begin immediately in the local areas where a disaster will begin, as we all know, while resources could be being accessed on a local or regional or even federal level. Another piece that's important in the preparedness program for all emergencies, including pediatric, is the role of the public information officers in the hospitals in Mississippi. Along with that, we provide much training to the hospitals in risk and crisis communication, because as we all know, if a disaster that involves pediatric patients, as Steve said, should there be an occurrence in a school or a daycare, that would be a huge matter of public concern. So the hospitals being prepared to manage the role of the media and how to map their messages and to be trained and skilled in the ways to communicate the things and the strategies that they are doing to take care of the pediatric population in a disaster is a huge piece of the training that we work with hospitals in. Another role that we at the Mississippi Hospital Association play in emergency response is that of serving in the Emergency Operations Center for the Emergency Services Function 8, which is health and medical, for the State Department of Public Health in Mississippi, to serve as a liaison, if you will, between the hospitals and those resources that the Department of Health can provide and the state can provide. It's also vital that we make sure that our hospitals, and we work daily to enhance the relationships that our hospitals have with the state and federal regions to obtain the equipment, supplies, medications, the different resources that they would need to be able to respond to a pediatric emergency. Keeping them connected and keeping them in training programs with their county emergency management agencies in Mississippi has been referred to as civil defense in some agencies. But once a hospital exceeds its capacity to have whichever supplies or medications, whatever the resource may be, then they will need to go through their county emergency management agency in Mississippi to request additional supplies. So we work very closely with them and encourage them to build that relationship pre-event with those resource agencies in their areas. Another role that we have in Mississippi is that we work very closely with the Department of Health, with their 9 districts that Ken has provided the information on to you, to connect those hospitals with their surveillance nurse to look at all of the infectious disease impact that a disaster might have with the pediatric populations in the state. So the Department of Health provides a surveillance nurse and who is trained and skilled in being able to help the hospitals to connect to the state public health labs, to be able to get the test back in the most expeditious manner for them. So looking at connecting and collaborating the hospitals to the key resources and the key avenues that they can get the best return on their request for supplies is a huge piece that the association plays. And for the network here as well, we see that as invaluable to our hospitals to have the relationships that we have with our peers in our neighboring states will be critical to the survival of our hospitals and treating the pediatric population in Mississippi.
Thank you, Joyce. So far, we've talked about this network, but we haven't shown a picture of it. And if you're in the audience wondering why that is, this is a virtual network. It's one that would come together in times of disaster. It doesn't exist in any other form than that. Which leads me to this. Maury, would you mind describing how the Surge Network would fit into the existing emergency response framework?
I'll do my best. We're learning as we go, and Jane and I often rode meetings together. Jane Reeves, one of my colleagues from here. And we'd go to a meeting, and we'd leave, and we'd get in the car and go, okay, where are we going with this? What's it becoming? And conversations all the way home, and then we'd get home and think we'd figured it out, and we'd go to another meeting, and more discussions would lead us to say, okay, now I'm beginning to understand, and so forth. I think this can cause confusion sometimes among the participants. I think in one case we talked earlier about maybe even a little resentment because it appeared that the network was going to be put into place and totally disrupt incident command, that sort of thing. That's not the case at all. I know I think of it at home, and I guess this is a social work type thing, but I call it the pediatric pool meeting, because to me it's a pool of resources. And we begin to gather those resources, see what's there, and how to access them efficiently, how to share them efficiently in an emergency. It has no effect on what EMA does, what public health does. It's simply an asset, a pool of resources. And that's my interpretation of it.
That's a good interpretation.
Andy, could I?
Yes, please. Certainly.
Because it occurred to me that with Maury's prompting, it strikes me that some of the model that we're getting at, not to use an ugly word that may have emerged in the last 6 or 7 months, but we are somewhat, as a group of states, trying to self-insure ourselves. We're trying to leverage the law of large numbers. I mean, if our pool, the pool is the notion that as we can see that as, certainly not that we have access, automatic access, but it is a first line backup as we would look to insurance. Not meant to pay the way completely, but it's something we fall back so that in a time of being overwhelmed, the fall is not nearly as far. The pushback is not nearly as great. That at least that's my take. I don't know if that's in the car when we go home this evening. Is that where we're going? But it's the best part of trying to see who's in the same boat, and why aren't we all looking in a parallel vision? And I think our group, by and large, is doing that. I'm sorry.
No, that was great. A great addition. Steve and I were talking on the way driving down this morning that while we've not seen the sharing of resources and the mutual aid on an exceptionally large scale, it's done on a fairly routine basis of where hospitals have relationships with one another. Leanne, I wonder if you might describe how that works, and if you would, talk about it in terms of from one state to another as it might relate here.
Great. Well, on a daily basis, as I mentioned earlier, we're faced with capacity constraints. And so we've actually developed some systems and tools to where we'll network with the other pediatric specialty hospitals in the region. And communications occur on a daily basis to help determine number of beds available, whether it's for a critical care bed, a neonatal intensive care unit bed, or a general acute care bed. And we are often trying to coordinate patient dispositions throughout the region on a daily basis. And so I look at this model and this network as something where we can apply some of those communications that we have currently in place with specialty hospitals to a broader range as well. One of our greatest needs is looking at, as we are a pediatric subspecialty trauma care facility, looking at what patients can we keep closer in their community and keep them closer at home and still receive the appropriate level of care and appropriate resources for them. And so this is a great network to be able to look at some of the models we have in place in the specialty population and apply that to the broader pediatric population as a whole.
Okay, thank you. There's an ongoing crisis that originated a few weeks back with the devastating earthquake in Haiti. I wonder if we could address some lessons that we might learn from observing the response to that, as that might apply, as those lessons might apply to us as we think about the way this network might function and things we need to be aware of as we move forward. Who would like to begin? Steve, you were talking
Sure.
on the way we had a discussion before this began, and you talked about moving resources there, and then as needs arose, moving patients out to other areas. Would you mind talking about that
Sure.
a bit?
I think with respect to that latter part, the issue with pediatrics is it's relatively hard to move the really high-end resources to where the problem is. And the problem with that approach also is you abandon your baseline service requirements.
What would be an example of a high-end resource?
So, for example, let me just take something really extreme. If you want to provide dialysis to pediatric patients in Haiti, and you take a bunch of dialysis resources, you won't have enough at home to be able to serve your population potentially. Mm-hmm. So, there's some real issues with that. And by having the resources concentrated, you tend to be able to produce more widgets than by starting to diffuse your resources. If you take your cardiothoracic surgeon and split one off and take them, you end up being more inefficient and having a lot of support and other issues. So it's a little tough to do that. And I think you have to really think it through as to whether you want to move your resources or bring the patient to you. And obviously, different contexts are going to drive the yin and yang of that. Mm-hmm. It's certainly a lot easier to move lower acuity resources around. And then also, when you get into moving critical pediatric patients around, that requires some expertise and skill as well. So it's probably something that we need to study a little bit harder and have a better understanding in the future. And I think that probably a regional effort like this probably will provide some more insight into some of those issues. As far as the bigger issue with Haiti, I think that it's providing us some really good reality testing that the advances that we've made since Katrina have probably been on the right path. One of the issues with Katrina and with most any other disaster is, first and foremost, you got to have security and protection. So you got to decontaminate the violence, you got to decontaminate the biological and chemical and nuclear issues if they happen to apply. And you can't really do much of that. And I think if you look at Haiti, they've actually done a pretty good job from the first-hand reports that we're getting back. Obviously, I don't have first-hand knowledge of this. And then I think the second part of it is that we've got some organizational improvements in this. And I think that one of the things I didn't really talk about in the beginning that's probably important in this is, in the past, we've tended to take an elemental approach to this rather than a functional approach. So what we have done in the past is say, here's 1,000 Band-Aids, here's 1,000 IVs, here's 1,000 bottles of saline or whatever else it is. And at the clinical level, that's a little tough because we really need to talk in terms of functionality. So, we tend to list who has a surgeon and who has an anesthesiologist and whatever. What I really want to know is who can provide a craniotomy or who can provide internal surgery in the abdomen or who can provide surgery on a bone. And having all those little elemental things categorized doesn't quite tell me that I have a functional element there. And so I think one of the things in the future, and I think we're drifting there fairly rapidly, and I think this also gets a little bit into what Leanne and some others talked a little bit about in understanding hospitals. In the past, we've kind of had the elemental approach. Yes, they have a neurosurgeon, yes, they have this or whatever, but we don't quite have a functional approach. And one of the things that we've been trying to work on a little bit in Alabama is understanding what really makes a pediatric hospital, and what functional components that you really want to know when things are tough. And so you want to know if they can ventilate a child, you want to know if they can perform a coeliotomy, you want to know if they can do a craniotomy and so forth. You want to know if they can do pediatric dialysis. And the list really is actually not that lengthy. So I think you're starting to see some of that. The DMAT teams and others recognize the pediatric shortfalls that they had in the past, and I think that they've created more of a functional approach for pediatrics on DMAT teams, and they've revised their supply and equipment roster and all of that. So I think you're probably going to see maybe a little bit more focus with that. We certainly have the language barrier issues in all of this, and we certainly are seeing the family unification issues in all of this. So I think we have some reality testing here that what we've talked about in the past actually is fairly universal in many of these kind of situations. So, and I think the other thing is that we've seen is this country and others are terribly altruistic, and people really want to help. And if we can focus on the systems issues so that we can enable things, that will probably have more impact than trying to focus on individuals one at a time.
In the emergency, the national framework, there's this concept of resource typing, and as you talked, I could see the influence of this functional approach has had on the resource typing effort that the resource typing work task force has been doing within the network, because we saw some elemental components, and then it has come back to be much more functional than it once was. And so the resource typing that we've done is broader than simply elements. So we have X number of widgets, it's capabilities,
Exactly.
And then we need to get to the definition of capacities. And there are systems in the states that deal with the issue of capacity. In Alabama, it's called AIMS. It's called in
SMART.
Would you mind describe what these things do, how these systems function?
In Mississippi, well, to back up, every state in the country is required to have an electronic bed and resource tracking system. And then states have chosen different systems to meet those minimum required standards. In Mississippi, it is SMART, the State Medical Assets and Resource Tracking Tool, SMARTT. And so it meets the guidelines that the federal government puts down for what has to be tracked to be reported to the funding agency for the program, which is ASPR in Mississippi, the Assistant Secretary for Preparedness and Response, through the Mississippi State Department of Health. So through that, we can identify different what the bed availability is, but as well we can and it's in Mississippi it is required for hospital licensure that you do report minimally once a day, 365 days a year, what your SMART status and capacity is. So it asks things like the different bed availabilities that you have. So it would track the pediatric bed availability. It also will go deeper and can go deeper to look at everything from some critical pharmaceuticals that might be available. It can has the fields for surge capacity, and it even has surge whether or not it would require decontamination. So, and it can be customized. And recently in Mississippi, we in our Metro Jackson area, in our capital city area, we had some water issues with some weather issues where we had water pipes that froze and burst. So our state hospitals were asked to update their SMART data on, and it can be done incrementally, on as rapidly or as less as the state requests that the hospitals will do that. The additional thing that we have in Mississippi, also and other states have, which is vital to the response capacity for the hospitals, is to be able to track staff, both clinical and non-clinical staff. Every state is also required to have that. It's referred to as ESAR-VIP in the federal documents, but in Mississippi it is VIPR, VIPR, Volunteers and Preparedness Registry. So that is something that we strongly encourage all the healthcare workers in Mississippi, as well as supportive personnel, to go into and pre-register. It allows us to track the capacities, the skill sets, the special training that healthcare workers have, such that if an emergency arose involving pediatrics, then that VIPR database could be queried to look for healthcare workers that would have pediatric skill sets. Then those persons could be notified and asked to respond to a needed area.
So with each state having a system, it would seem fairly reasonable then that they all interface and that you can see every other state's resource.
That is not the case. Some states, each state has administrative capacity, and each state reports their data to a federal point. And so from that federal point, then they can see all of the state's data. Another very important tool that we have in Mississippi that we use and has been very advantageous to us is something called and referred to as Mississippi MedCom. So this is a communications hub for the state of Mississippi that does connect all hospitals in the state to this central hub, and it connects from this hub. They are connected to the Mississippi State Department of Health. They are connected to Mississippi Emergency Management Agency, to the Mississippi Department of Transportation, and to other supportive agencies that would be critical that we have open lines of communication in response to emergencies in the state. The MedCom, Mississippi MedCom, is manned 24/7, 365, and so hospitals can call into MedCom, and MedCom can also communicate outward to the hospitals to notify them of any incident that's occurring in their area. We also we work very closely with our Mississippi Department of Public Safety in the state of Mississippi, and have provided 24/7, 365 answerable numbers for hospitals, such that the Department of Public Safety could notify hospitals in an impacted area to give them advance notice that an event was occurring in their area. And oftentimes that allows those hospitals that golden hour prep time to be able to ramp up, or maybe hold over a shift of employees should an event be coming, that can many times improve the outcome for the victims that are coming into the hospital.
You mentioned, I'm sorry, go ahead.
If I could add on to what you shared, I think one of the most tangible outcomes of our network thus far has been getting everyone on a common ground as far as the language that we speak. In Tennessee, we have the Hospital Resource Tracking System, or HERTS as we refer to it, and to know that that links with, or it is the similar system to your SMART system. And so I feel like one of the most positive outcomes that we've had thus far of our network has been to actually create a grid of the different systems that we have in each of our states, whether it's the ESAR VIP system or the resource tracking system. So we're all on a common ground as far as our language. And when we do have interstate communications, that we're speaking the same language.
Absolutely, Leanne.
Steve?
A few years ago, these information systems were kind of in their infancy, and one of the things that we realized that was one of the catalysts for starting to talk about such a network was the difficulty of communicating through the official channels. And if I had an issue and I needed to get it to Nashville or whatever, to go from our hospital to the local EMA, to the county EMA, to the state EMA, have it processed, go over to the next state EMA, and go through all that was a very difficult process. And because of communication systems that weren't real well meshed, and because of other issues, it took many, many hours to do that. And also there was the other overlay of the states had to negotiate who was going to get the bill and produce a formal document to do it. Meanwhile, I'm sitting there with somebody who's critically ill that I can't really do much with because of my constraints. And so this was part of this, in that we could more effectively communicate without going through the official channels. I think we've come a long way in that, and that's starting to have a much lower gap. And I think that's where the future of this is going to be as well, is that we will get to the point where we have much better integration and we have finer granularity so that we can be more insightful, more efficient in all this. But this also just goes to show, as Leanne and others have correctly shown, by having this kind of network, not only can you have effector things, but you can have affector things. And so we are understanding the problems or the issues a little bit better, and we can discuss them with the rest of the system, and others can come to a more insightful solution. So I think that that's kind of an example of how this kind of network can actually help. And I think when we were originally thinking about this a little bit, there were probably a couple other issues or advantages along these lines. One is because the subject matter experts are so sparse, by having a regional approach, you can have a consortium of subject matter experts. So if you need to figure out what you're going to do, you may be able to reduce your risk. And I think we've had the same thoughts, too, about the insurance risk mitigation issue of this as well. And then I think probably the other part of this was a few years ago with Hicks organizational schemes coming out and whatever, we realized that they were not quite structured right, and there needed to be the capability to task organize them and modify them ad hoc in order to deal with specific contexts. So if you had a pediatric specific context, you might want to add a pediatric subject matter expert into your organizational scheme to be able to deal with that. If you've got tropical disease issues from Haiti, you need to be able to adjust that. And so I think we were trying to make the argument that maybe having a more flexible approach to that and realizing that you might want to task organize a little bit was another advantage of such a network.
To make certain the audience understands, the acronym HICS, H-I-C-S, represents Hospital Incident Command System, I believe. That's correct. It probably represents several other things, but that, in this context,
at least that.
It's at least that. In thinking about this network as a system and the way it relates to what goes on in the states, in almost every system where there are boundaries is usually where issues arise. And I wonder if we might address some issues about interstate versus intrastate actions as we move. If we have an incident in one state that needs resources from another, or what have you, what are the issues surrounding bringing those resources to bear? And I think it varies in two contexts. One, we might address it from the standpoint if it's a declared emergency, if the government agencies say, okay, there's a disaster. The other situation is when it doesn't meet that criteria, that it's big, a school or something, but it's not one of those disasters that's been declared, but it affects its near a state boundary. Let's talk about the issues there. Murray, might you address for us this declaration? What happens in a declaration? What changes in the world, in the region, if there's a declared emergency that eliminates any cross-state line issues?
I think one thing we've learned in this process, I know at public health there are situations where professions can go into other states and practice for a certain length of time. But one of the issues that we have faced is working with some of our licensing boards for instant credentialing of people coming in, or people going to other states, and their abilities to be able to practice, whether it be social work, medicine, nursing, the whole 9 yards. It's something that we need to resolve, because it's just something we've got to have if something really big happens. And I think it's going to be on the radar for future meetings to see how we can better do this. Another's use of volunteers. I know during Safe and Sound conference, for instance, one thing that I really had never thought of was we had a speaker from Canada's Red Cross come, and she spoke on the sexual abuse of children during a disaster. And I was floored. Naive, but floored. And there were over 400 agencies worldwide that were facing some kind of charges for this. So the question of, do you do background checks? Who's going to pay for the background check? All of these things, especially when you're dealing with children. Do you use daycare workers as volunteers because they've been through this process? A lot of that has to be considered. So that's just a few of the things that come to mind there.
And Andy, the other issue is making sure that all the parties involved are well versed in EMAC, Emergency Mutual Aid Compacts, and that process. In a declaration, that would be the process that the states would use to share resources across state lines.
If it doesn't rise to that occasion, where there isn't a declared one, is it just on the goodwill, or is it relationship from one hospital to another? Especially hospitals have relationships that mitigate this, do they not?
I believe so. I think there's probably several flavors of all this. First of all, there's a lot of major metropolitan areas that sit on state boundaries, so this happens on a regular basis.
Memphis, Tennessee being a good example.
To some degree. And basically, the clinical issues stay the same. We're all Americans, we're all human beings, and that doesn't change anything. But you're exactly right. The legal and the financial and the bureaucratic issues in particular do have some real impact when you start crossing jurisdictional lines. Most jurisdictions want to try to facilitate things, but the law is the law, and financial responsibility is financial responsibility. And it would be nice if we could unwind some of these kind of things, but unfortunately, in order to unwind them, you can't usually do it real time and have the legislature hold a special session or whatever to unwind things that they have to unwind. But the risk of the whole thing is, I think in general healthcare providers are going to do what's in the patient's best interest, but you put a pretty significant tax on those providers when you don't reimburse them, and they have to eat all the bill. And that's the real risk of this whole thing, is if we don't have some sensitivity to that and try to repair that to some degree, bankrupting somebody leaves a community without any resources, and that's probably not a good thing.
Leanne, you were mentioning off the air before the program began what you understand, and we'll use the Haiti example of patients coming to the hospital and being able to be reimbursed at a certain rate, and then you said, what happens to their longer term care once we discharge them? Would you mind recounting that for us?
Certainly, and I think going back to what Steve had mentioned earlier as well, especially with the situation in Haiti, we're not just dealing with the patient, but the entire family and support system for that child as well, and making sure that we're looking at the full picture there. And that is a challenge. So in the immediate need, giving the appropriate medical care for the child that is needed, but also looking at the long-term care. So once their hospitalization is completed, what follow-up procedures or follow-up services are needed to really provide appropriate care, and that's the longer-term view that I think we still have to work out as well. With Haiti in particular, looking at what are the family support systems in the community and what are those resources to help normalize them and be able to provide the appropriate care in those situations. And so it gets very complicated when you add in those factors, that we're not just looking at the patient, but we're looking at their family and their long-term needs as well.
When we think about one of the things that we haven't addressed in any depth yet is what we've talked about it a bit here today, communication. Mm-hmm. And part of that communication is information about the patient and so forth. How does that move with them in the current system? How does information that, if you're moving a patient from one hospital to another, how is information about whatever patient information gets carried, how is that carried forth? And would that change necessarily in a disaster?
I'll take a stab at that. Generally, what happens is one of a few formats is utilized. One is person-to-person communication to try to give the salient information by telephone or whatever. Second is providing paperwork or electronic documents and images or results or whatever it is that are pertinent and having them clipped to the patient or whatever. We're still embryonic in being able to have electronic to electronic transfers. We can fax things, but it's kind of the Model T electronic solution in all of this. So I think in the future, this is another information systems integration enablement issue that will probably get a fair amount of attention.
Steve, to add on to that, that's something that we always factor into our drills that we do whenever we're doing a disaster drill at our organization and having patients transferred from one facility to the next. And we've made improvements, but there's still a long way to go. And I think back to Katrina and having the patients coming in for that and the limited information that you received on them and at times inaccurate information that you were receiving to plan and be able to receive those patients accordingly. So it's certainly a challenge.
And I think there's another dimension to this, too, is people with chronic health care issues and special needs, all too often that information is not archived in a way that it can be discoverable. Patients probably would benefit from having that information in their hand or medical alert bracelets or something that give a electronic archiving location or a contact number where you can find that. And that's the real struggle that I have in emergency medicine, is somebody that has some unusual, very serious, sensitive, chronic medical problem, and there's no way that I can figure out what it is, and now we have a pretty big jeopardy situation. So I think we probably need to focus on the preparedness mitigation piece of this patient information issue, as well as transmitting the acute information as well.
So is it reasonable as a parent, if I have the means and the capability, should I see that there's a, I think you called it a medical, a bracelet or
Some
something?
kind of medical notice.
Some kind of record that I would carry or the child would carry.
And so this is maybe a potential role for the network as well, in that if I know that a patient's from Memphis and they're pediatric, I know probably which hospital takes care of them there, and I might be able to stand a chance of getting somebody to read it to me or whatever. Again, we've got some regulatory issues that interfere with that potentially as well. So this is something that is probably worthy of future development too.
We've identified a few issues around state boundaries. We've talked about credentialing. We've talked about the transfer of information. One thing we haven't talked about is transportation. Is the transportation system, the patient transportation system, adequate? Are there any barriers there between movement of ambulances and patient transport systems from one state to another?
In my experience, the actual movement, no, and this tends to be a federal issue rather than a state issue for most things. The more important clinical issue is that pediatric patients need pediatric capable providers en route when they're critically ill, and having the equipment and supplies and providers, that's a very limited commodity as well. So if we ended up having a big issue, we would need to call in teams from our sister hospitals.
See, I understand we have an email, and thank you, Ryder, for sending in a question or comment.
We do have an email. We have an email from Stuart in Pennsylvania, and he writes, do you have suggestions for how other states or regions would get started in developing such a network? Are there any brief lessons to share?
I can maybe tell you how we got started from the very beginning, and maybe that would help them a little bit, and perhaps the others have some advice on how to follow through. I think probably the place to start is to identify the institutions that may be able to collaborate and make a phone call or take a drive and go talk to them a little bit and say, you know, we think we have this issue. Are you interested in working on it? And I found that generally most people are very interested, or they even go so far as to say, yeah, we kind of had the same thoughts, but we didn't quite know where to start. So I think that's exactly where I would start. And the other thing is I would call your state capital and ask for the EMS or other appropriate subdivision within the State Department of Health, and have a little chat with them and say, hey, we recognize an issue. Can you help us coordinate it and start working on it? And then once you have a core group of committed folks, then carrying it forward is really the issue, and perhaps others on the panel can talk to that part of it.
I think it's important to see what's around you as far as other things that are happening that might stop you from recreating the wheel. I know at our last meeting we had some representatives from the state of Texas there who seem to be on it a good bit, and we're looking forward to possibly going out to observe a tabletop, to have them observe something here, to serve as evaluators and so forth. I think it's important to recognize what might go wrong in this process as far as the things that I remember our first meeting at Children's, and for some strange reason I got put on the finance section to work on. And I was like, okay, yes, there are going to be problems, but you need to think through those. Again, identify them. And if there is another network, talk to them. See what they've been through. See where they're going. And I think that will help tremendously in your efforts.
And our network is still very much under development. We still have a lot of questions that we have yet to solve, but I think we've gone through several iterations of our handbook that we've tagged it, and we've gone from being extremely detailed to going more broader in scope. And so I think as we work through all the details, we're realizing what we can do and what we can't do, and how we need to work within the already established state and federal frameworks as well.
Excellent comment. Ken?
Well, I would chime in, certainly, hopefully dovetailing with the previous comments, but particularly for Stewart in Pennsylvania, it certainly seems clear to me that the State Department of Public Health, or whatever moniker of that function is served in Pennsylvania, the added feature in Pennsylvania, not knowing where Stewart is close to Philadelphia or not, is that one of the premier children's hospitals in the world is CHOP, Children's Hospital of Philadelphia or Pennsylvania, whatever the P. I can't imagine, with similar motivations that Leanne has referenced here, that they would embrace that willingness that exists out in other communities within Pennsylvania as a nugget. I think more nearly the problem is when one does begin to cross state boundaries, but Pennsylvania is such a hugely endowed state in a number of ways: population, resources, geographical expanse, that coupled with a Philadelphia experience on the east side and a strong presence in Pittsburgh on the west side, it sounds like an inviting setting. I would hope that we'd have an opportunity to follow up with Stewart in a year or so and see what kind of genesis is possible to pursue with Harrisburg in the middle.
The other comment I would have is New York City's done quite a bit with the megalopolis type of model and all this, and in that case the jurisdictional issues start to fade, and when you have 5 or 6 children's hospitals within a few miles of each other and they're all within the city limits, it's a little different thing. So if you're talking about the Philadelphia solution, you may want to look to New York a little bit. If you're talking about the Harrisburg or more rural issue, then perhaps talking to some of the people here elsewhere in that kind of model would be helpful.
Thank you very much. And Stewart, I would encourage you to go to the South Central Center for Public Health Preparedness website or the University of Alabama Birmingham School of Public Health, and you can find my email address there and telephone number, and I welcome you to call me, and we're glad to talk with you about this network and how it got started and the kind of things that we might be able to share with you in terms of resources. We've come to the end of our time today. We hope you've enjoyed today's broadcast about the Southeast Regional Pediatric Disaster Surge Response Network. I hope it's been informative and insightful in terms of why and how to begin planning for a regional pediatric disaster surge response. This concludes today's broadcast. I would like to thank our panelists. Thank you all very much for being here today, and I hope that you enjoyed the program. Our next Preparedness Center program is Thursday, February 18th from 12.